The vestibulocochlear nerve. I have very, very little to say about this nerve per se. I mean, it is the nerve that brings information back from your vestibular system, which are your set of semicircular canals, which are these, and you'll learn about these, I hope, in neuroanatomy. These actually semicircular shaped canals, which are at right angles that provide information to your brain about accelerations of your head in space. So every time you go like that, it's quickly turning up and down. That information is picked up by the fluid motions within the semicircular canals and transmitted to your brain about the acceleration of your head in space. And there are these other things called the saccule and utricle, which are little tiny collections of fluid with specialized hair cells and things like that, which respond to the position, not the acceleration, but the actual position of your head in space. So if it's tilted, the cells have these little thing called otoliths, which press down on the cilia of the cells, and it measures the gravity vector in relationship to your head, and so it tells you about the position of your head in space if it's tilted to one side or forward or backward. That nerve, that vestibular system, plus the cochlea, which is the organ of hearing, which measures sound waves and their frequencies. I'm not going to talk anything about that except a little bit about the gross anatomy of hearing, really. Testing the vestibular system is very complex and really is not done routinely, and you almost have to have symptoms for anybody to test it. You have to really know what you're doing. On the other hand, testing hearing is a standard sort of thing you do in any kind of physical exam. And you have to know that there are two ways that your cochlea can be stimulated. Your cochlea can be stimulated by a mechanism called air conduction, which is moving of the eardrum and all the little bones attached to it. And that is air impacting the eardrum. Or bone conduction, which is vibrating the actual bones of your skull. And that vibration is sent directly to the cochlea, bypassing the eardrum and all those little bones. Now here is the mechanism of air conduction. Use your external ear, external auditory meatus. Here is the eardrum itself. Here is the first of the auditory ossicles, the malleus, which is the one attached to the eardrum. Here's the second one, the incus, which articulates with the malleus. And here is the horseshoe-shaped one called the stapes, which articulates with the incus. And then the footplate of the stapes, this sort of oval thing you can see a bit of here, sits in what's called the oval window. And the oval window is connected to or presses right up against the fluid within your cochlea. So when the eardrum bounces back and forth, the malleus does, the incus does, the stapes is driven like a piston in this oval window, and that sets up waves within the fluid of your cochlea. And that is the mechanism of air conduction. And the mechanism of bone conduction is simply you vibrate your bones and it gets transmitted to the petrous temporal, and that also sets up waves within the cochlea. You can lose your hearing either because you have a problem with your conductive mechanism, that is the eardrum or those ossicles, or you can lose your hearing because you have damage to the eighth nerve or to the cochlea itself. If you have damage to the eighth nerve or cochlea, that's called a sensory neural hearing loss. If you have damage to the conductive mechanism, that's called a conductive hearing loss. Here is how you test for hearing, whether you have any kind of hearing loss at all.
The auditory or eighth cranial nerve is both auditory, that is hearing, and vestibular or balance. Hearing is assessed in the office by using a mask and whispering in one ear. Enrica, I'm going to whisper some numbers to you and you repeat them after me. Close your eyes, please.
392.
Correct. The reason for using the mask is a patient could have a severe conductive hearing loss or sensory neural hearing loss, and if you did not mask, they could be hearing it with the opposite ear and not be aware of that. This is repeated on the other side.
All right, so that's really, and you'll see a different way to do this, but that's the basics are test you tell if a person has a hearing loss. You can either use that card to mask the noise, you can rub your fingers together and whisper into the ear using the fingers to mask the noise of the opposite, on the opposite side. Now, once you have determined that a person has a hearing loss through that method, you don't know still whether it's a conductive hearing loss or a central neural hearing loss. And there are two ways that you can test that will help you make that determination. And you're going to see examples of a person doing both of these, but I will describe them to you. One is called the Weber test. The Weber test is a test where you put a vibrating tuning fork right on the top or the apex of one's head and press down onto their skull and set the bone in motion. All right? If a person has a hearing loss, they will not hear this as being equally loud on both sides. They will hear it as being louder on one side or the other. But here is the trick with this. It's pretty obvious, it would seem to me, that if you have a sensory neural hearing loss, you will in fact hear it as louder on the right side than on the left side. You're vibrating your cochlea directly through the bone. And if the left cochlea or the left vestibulocochlear nerve is not operating, you will hear this sound as being louder on the right side. But less obvious is that if you have a conductive hearing loss on the right side, you will also hear the sound as being louder on the right side. Because what happens is in normal hearing is that anything that's sent via the bone to your cochlea is in competition with room noise and the noise of our environment. And if you have a conductive hearing loss, that noise of the room or your environment is a poorer competitor. So anything that's sent directly to the bone seems louder than it does on the normal side. So the basis of a Weber test is that the sound will lateralize to the good side in a sensory neural hearing loss, but will lateralize to the bad side in a conductive hearing loss. So if you know a person has hearing loss on their left side, and the sound lateralizes to the right side, you can deduce that the left-sided loss was sensory neural. If you know a person has a hearing loss on the right side, and it lateralizes to the right side, you can deduce that that was a conductive hearing loss. Yes?
If there's a sensory neural hearing loss, how do they hear anything on that side at all?
Well, these loss, when I say loss, I don't mean complete obliteration thereof.
Okay.
Most diseases start off at progressive losses of hearing. Obviously, if you have a complete sensory hearing loss, if you do this test and a person has a complete left sensory neural hearing loss, you say, where do you hear the tuning fork? Do you hear it in the middle of your head, or does it sound equally loud on both sides? And they say, no, I only hear it on the right side. So that would be a complete one. Otherwise, if you had a partial one, they would say it seems louder. It seems more to the right than to the left. There's a second test, because this one is sort of hard to interpret, really, because you have to start using your brain. But there's a second test, which is called the Rinne test. And the Rinne test is simply a test in which you take this same tuning fork, you put its stem on the mastoid process with the actual vibrating tines aimed away from your ear, and there's two ways to do this. You'll see it done both ways. You either hold it there until the sound can no longer be heard. Then you move it to the ear and you ask the person, can you hear it now? If a person has a normal air conduction system, they will hear for an additional equal length of time as they heard it on the mastoid process, because the air conductive system is so much more sensitive than the bone system. So if you heard it when it was against the back of your mastoid process for 15 seconds, and then you put it by the side of the ear, and they say, oh, yes, I hear it again, they should be able to hear it for at least another 15 seconds. If they don't hear it at all when you move it to the in front of the ear, that means they have a complete conductive hearing loss. Or if they hear it for a very short time, it's a partial conductive hearing loss. That's one way to do it. The other simpler way is, in fact, to just put it on the mastoid process and say, you hear that? And they say, yes. and you put it in front of, now this, you're not going to hear it if you have a complete sensory neural loss. If a complete sensory neural loss, they're not going to hear it anywhere, all right? But if you have partial losses, you put it, and this is actually a test for conductive, better for conductive. You put it on the mastoid, you say, do you hear it? They say, yes. You bring it by the ear, and they say, which is louder, in front of the ear or on the bone? And if they say in front of the ear, that's the normal response. It should always appear louder when you have it stimulating in front of your eardrum by your eardrum than it would be on the bone stimulation of the mastoid. Now, you have these two tests. Weber is, by most otolaryngologists, dismissed as unreliable. That was the first test, the Weber test. The one required you to think some more. That one is considered unreliable. There's too many false positives, too many false negatives. People say they hear it louder on one side than the other when in fact their hearing is equally good on both sides. Or people who have problems say, no, I hear it right in the middle. So you're not, they don't believe in doing the Weber test anymore. On the other hand, is Katie here or not? Do they teach you to do a Weber test? Yeah, they teach you to do it. Everybody, it's like a tradition handed down for generations. You're going to be taught to do the Weber test, and you're going to see it done in a moment or two. The Rene test is considered a much better test for whether you have an air conduction problem or not. If you have a partial sensory neural problem, you'll get a normal Rene test. Let's say you lost half of your hearing in one ear due to a partial damage to your cochlea or nerve. Still, when you do this Rene test, it will sound louder in front of the eardrum than it will against the bone. And the sound will last longer in front of the eardrum than it will against the bone, because this is really only a test of whether your air conduction is as much better than bone as it should be. The one where the otolaryngologists say it's most reliable if you simply ask a person, where is it louder, rather than the duration. But you're going to see it done in both ways. We have a new doctor.
The eighth cranial nerve, the acoustic nerve, has two divisions. The one that we're going to test today is the cochlear division. And we're going to first test auditory acuity. Do you hear that? Mm-hmm. And what is it that you hear?
Your fingers rubbing together.
How about over here?
Same.
Is there any difference between the two sides?
No.
Okay. We can further test that by doing the...
Now, you see, that's a very different way than the Canadian doctor did. In fact, the Canadian doctor's way is probably better than this way.
The Weber-Rene test. The Weber test is actually using a tuning fork, placing it on the forehead. And do you hear that on one side or the other or the middle?
In the middle.
Good. And then the Rene, we're placing it back on the mastoid. Can you hear that?
Mm-hmm.
Can you tell me when you can no longer hear it?
Okay.
Can you hear it now?
Yes.
And we should do the same thing for the other side, but another way to screen with a Rene is to ask the patient which is loudest. Number 1 at the mastoid, or number 2 air conduction.
Number 2.
And that's the correct answer. That would be the normal response.
All right. Now, here's a person who has a hearing loss.
Can you hear that there? Hear it over here? Harder to hear over there? Okay. All right. Can you feel it in the middle or to one side? Feel it over there? Okay. All right. Can you feel it back here? Okay. Tell me when it stops.
It stopped.
Can you still hear it? Okay. Tell me when it stops over here.
It stopped.
Can you hear it? No.
So that's, at least you got the same result from both of them. As I said, the Rene is generally considered more accurate and reliable. All right, that's the only extent to which we will cover in this course hearing in the vestibulocochlear nerve. Glossopharyngeal nerve. Glossopharyngeal nerve, an extremely complicated nerve, almost as complicated as the facial nerve, and yet at the same time is of no importance whatsoever. And it's got all these branches and it does all these things, and no one really cares if it works or not. Among the branches it has, we don't dissect this branch. We don't dissect, we do dissect some of it, obviously, we saw it last time. The tympanic branch, a tiny little branch given off by the glossopharyngeal immediately after it exits the jugular foramen. And then that pierces the bone between the jugular foramen and the carotid foramen and enters a little canal within that portion of the petrous temporal that takes it into the middle ear cavity, where it participates with a branch of the facial nerve and a branch from the internal carotid plexus in a plexus, small plexus of nerves in the middle ear cavity called, in the lateral wall really, medial wall, called the tympanic plexus. While it's in there, it is general sensory to your middle ear. It is, if you have earache, it's through the glossopharyngeal that pain passes. It is sensory to the mastoid air cells, which are these air pockets behind your middle ear, and to the eustachian tube, which is traveling from your middle ear to the nasopharynx. It also brings to that tympanic plexus the preganglionic parasympathetic fibers, which have exited the brain with the glossopharyngeal nerve for the parotid gland. These same fibers emerge from the tympanic plexus as a nerve which is called the lesser petrosal nerve. We will never see the lesser petrosal nerve. We won't see any of these things. And the lesser petrosal nerve exits the middle cranial fossa either through the foramen ovale along with V3 or through a little hole medial to V3 and brings itself into the infratemporal fossa, just deep to V3. And there it encounters a ganglion called the otic ganglion. I have seen two, I've been maybe three in my life, meaning I couldn't agree on with the student who showed me the third one whether I thought it was really it or not. You will probably not see an otic ganglion unless you live to be as old as I am. All right? That otic ganglion sits just deep to V3, immediately inferior to the foramen ovale, and the lesser petrosal nerve, which is carrying those preganglionic parasympathetics, which have traveled out of the brain with the glossopharyngeal, synapse on the cells of the otic ganglion, it's a parasympathetic ganglion, and the postganglionics then join the auriculotemporal nerve, which is coming off of V3, and are brought with that out laterally, and the auriculotemporal passes through the parotid gland on its way to the skin of the ear and the temple, and gives off all of those postganglionics to the parotid gland. You saw the auriculotemporal and the infratemporal fossa. It was many times bigger than what you saw here in front of the ear, because when you see it in the infratemporal fossa, it's carrying all those parasympathetic postganglionics for the parotid gland. When you see it in front of the ear, those are all gone from it. So you just have its little twig, which is sensory. But that's one of the things the glossopharyngeal does. It controls parotid salivary gland secretion. Then, as it's passing down the back of the stylopharyngeus muscle, something we should have seen Monday, it gives off a branch to the stylopharyngeus muscle, a striated muscle of the stylopharyngeus. So this is a somatic motor branch. Then it generally gives off a branch to the pharynx itself, where most places will tell you it is just sensory to the pharynx. But there's been some new work which indicates that, in fact, some of the deeper layer of the pharyngeal constrictor muscles are innervated by glossopharyngeal fibers. You would never be held responsible for that. And then finally, then at some point in its course, it gives off a branch to the carotid sinus, which measures your blood pressure, and to the carotid body, which is something I've never seen, but it's said to sit in between the internal and external carotid at the bifurcation, and measures oxygen or carbon dioxide or something like that in your blood. And then finally, it gives off the glossal branch, which we will again you'll be asked to find near the end of our dissection of head and neck. And that is general sensory, meaning pain and touch and things like that, to the back 1/3 of your tongue. General sensory to the front 2/3 was lingual nerve. And it is taste to the posterior 1/3 of your tongue. Taste to the anterior 2/3 was a facial through chorda tympani. Now, none of these things are important, really. A person can do quite well without any of them. I'll show you the test for the glossopharyngeal nerve, and I'll explain to you why it's really hardly ever done. It's for two reasons it's hardly ever done.
The reflex action, we're going to actually look at the gag reflex. Have you open your mouth, tilt your head back just a little bit, good, and I'm just going to gag you. That was a good gag. Okay.
this is hardly ever done because people don't really like to be gagged. You think you're testing the glossopharyngeal as the sensory side of this, and the gag itself, which is pharyngeal constriction, is considered by and large to be a vagal innervated. The pharyngeal constrictors are predominantly, despite what I said about the glossopharyngeal, are predominantly innervated by the vagus. So you're looking at a reflex which is glossopharyngeal on the sensory side and vagus on the motor side. But it's not really a good way, and this is how I'm going to tell you how you know that. There is a condition in which the glossopharyngeal is important, and it's called glossopharyngeal neuralgia, which is just like trigeminal neuralgia. That is a sharp, almost excruciating pain radiating from the distribution of, in this case, not the trigeminal nerve, but the glossopharyngeal nerve. So people get these episodes of horrible pain which radiates from the back of their tongue through their throat towards their ear and into their mastoid process. Very uncomfortable, very disconcerting. In the old days, glossopharyngeal neuralgia was actually treated, if you could, by going inside and cutting the glossopharyngeal nerve, because no one cares about what it does. All right, so if you didn't have it, it didn't make a difference. Better not to have one than to have all that pain coming from the distribution of the glossopharyngeal. And when you did that, it turns out there were lots of reports saying, well, I cut the glossopharyngeal nerve, but they didn't lose their gag reflex, and they didn't lose taste on the posterior third of the tongue, and they didn't seem to lose anything. And so, in fact, it looks to me, this has never been demonstrated, by anatomists, that the vagus probably does a lot of these things that the glossopharyngeal, or overlaps and does a lot of the same things the glossopharyngeal is said to do, maybe with exception of the stylopharyngeus muscle, which it means absolutely nothing, that muscle. So the fact is that I guess no one did test whether you lost salivation from your parotid salivary gland, and that I will bet you did do, but then you have all these other salivary glands that can make up for it. So maybe, that's the thing you would suffer if you had a glossopharyngeal that was cut. You wouldn't have salivation from the ipsilateral parotid gland.
Did the pain go away when they cut it?
Yes, the pain goes away when you cut the nerve, that's for sure. They now no longer do this because actually the same folks who believe that trigeminal neuralgia is caused by a little pulsating blood vessel say that you can find a pulsating blood vessel pressing on the glossopharyngeal. They'll go in and do cranial surgery, and they'll just either tie off that vessel or put a little cotton thing between the vessel and the nerve.
Is that because they make more money off of doing that than cutting it?
No, cutting it, it's just a bad idea to cut nerves that if you don't need to. I mean, I just told you the papers say, well, people don't seem to be bothered by it at all, but still, if you can treat it without cutting, you're better off to do it. I don't think you make more money. I think you make the same amount of money. And you might need your parotid salivary gland one day. All right. So that's it for glossopharyngeal. Now we get to a nerve which is not unimportant. The nerve is important, and that is the vagus nerve. The vagus nerve has some branches which are not terribly important, like the auricular branch, which does some skin around the external auditory meatus. It joins with the auricular branch of the facial. Its only consequence would be that if you have an irritative lesion of your vagus nerve, I don't know how often this happens, they do describe sometimes pain around your external auditory meatus, but otherwise it's not a very consequential thing. It has some branches which are more consequential. The pharyngeal branch, which is somatic motor, the main somatic motor supply to the pharynx. That's pretty certain. It is also parasympathetic to pharyngeal glands. The pharyngeal branch has palatal branches, which are somatic motor to most of the muscles of your palate. Now, the muscles of your palate are illustrated here. This is a non-skin or the mucous membrane is intact on the left side. The mucous membrane of the person's throat has been removed in the right picture to show the muscles. There is this fold you will see in dissection between your soft palate and your tongue called the palato-glossal fold, and between your soft palate and the lateral wall of your pharynx called the palatopharyngeal fold. Those names, palato-glossal, palatopharyngeal, are anatomist names. Clinicians tend to call this the anterior faucial pillar. The fauces is the junction between your oral cavity and your oral pharynx. Behind it, clinicians tend to call this the anterior faucial pillar, and they call this fold the posterior faucial pillar. Beneath each fold of mucous membrane is a muscle. The palatal-glossus is the muscle beneath the anterior pillar, and the palatopharyngeus is the muscle deep to or beneath the mucous membrane of the posterior pillar. Then there's some other palatal muscles here. One we know about, tensor veli palatini, right there, and then one we'll talk about now, levator veli palatini, although Dr. Degum also had mentioned it. You know this. You've committed this to memory by now. All muscles of the head and neck with tension in the name are innervated by V3. The second rule of Stern's law: muscles with the letters palat in their name are innervated by the vagus. All right? There's only one occasion when this could not be true, and that is when this takes precedence. So the tensor veli palatini is innervated by V3, but all of the other muscles with palat in their name are innervated by the vagus. In fact, even a muscle here called the musculus uvuli, which is in your soft palate, is innervated by, even though it doesn't have palat in its name. So palatal muscles are innervated by the vagus, except tensor veli palatini. The vagus also has in its most important branches, well, I can't say most important because these are not trivial, but it's certainly very important branches are laryngeal branches, two of which you have already, the only two of which you've already seen. The superior laryngeal branch, which has an internal and an external branch, and the recurrent laryngeal branch, which you have seen. Many of you have asked me in lab, well, what about the inferior laryngeal nerve? The inferior laryngeal nerve is the name given to the recurrent laryngeal nerve after it enters the larynx itself. We've seen it outside the larynx. Once it enters the larynx, it's called inferior laryngeal. That's only by anatomists. And it's done because we've already named this superior, so we have to have an inferior. Dr. Larson explained, in the first lecture of class, if you have one, you have to have the other. But no doctor in the history of the world ever talks about inferior laryngeal nerve. They only talk about the recurrent. So that's it. So, I mean, it's a wasted name. These branches, these two laryngeal branches, one of them, the recurrent laryngeal, is somatic motor to most of the laryngeal muscles. The external laryngeal branch of the superior laryngeal is somatic motor to a muscle called cricothyroid, and it's actually somatic motor to the inferior constrictor of the pharynx as well. It contributes to the inferior constrictor innervation. They are parasympathetic. Both of them are parasympathetic to the larynx. The internal laryngeal branch of the superior is parasympathetic from the vocal folds up. The recurrent laryngeal is parasympathetic from the vocal folds down. And they both are sensory to the larynx. The internal laryngeal is sensory from the vocal folds up. And the recurrent is sensory from the vocal folds down. And obviously they meet at the vocal folds. And then, of course, all this other stuff that the vagus does that we've learned about in the chest and in the abdomen. So the vagus does many, many things.
Just repeat what it was somatic motor to, the laryngeal branches.
All right. The external laryngeal nerve, a branch of the superior, is somatic motor primarily to the cricothyroid. But I, just for the sake of completeness, said also to some of the inferior pharyngeal constrictor. The recurrent is somatic motor to all of the laryngeal muscles with the exception of the cricothyroid. In fact, all those other laryngeal muscles you cannot see unless you strip the mucous membrane off the larynx, and we'll see one or two of them later in dissection. Those are called internal laryngeal muscles because they're inside the larynx. The cricothyroid is called an external laryngeal muscle because you can see it without opening up the larynx, and you've seen it all, and that's done by the external laryngeal nerve. Here is this nerve which does 1,000,001 things. Here's its test.
We can also actually have them open their mouth, stick out the tongue, tilt your head back a little bit, and say ah. Ah. And watching the action of the palate, say ah again. Ah. And that's totally normal.
That's it. You just look to see if one muscle and one thing that it does, the levator veli palatini, is working properly. If the levator veli palatini is working properly, you decide that the vagus is working properly because it's given off a branch given off very early, and it seems to work quite well as a diagnostic indicator. So that's the one and a very easy and quick test you do for the vagus. I'll show you. Yes.
Could you have like a localized and then distal problem like you did with Bell's palsy?
You can certainly have, and we'll see the symptoms of that. I'm talking about a person who's coming in who's asymptomatic as far as you're concerned. A person comes into your office asymptomatic, you're just doing a routine physical for them. That's how you test for the vagus. If they have symptoms, you can start to, then there's a different issue, because then you might think, well, maybe the nerve is damaged elsewhere along its course. Here is a person who, in fact, does have a problem with his vagus. So, you see his palate does not rise symmetrically when he says, I'll play it for you again. I'm guessing does anyone know the language that guy's speaking to him in?
Spanish.
That's Spanish? Okay. Then a lot of people know that language. Not I don't. His palate rises to his left side. His uvula shifts to his left side because as the palate rises, it is being pulled to the left. And so that person has a paralysis of his right levator veli palatini, because the left one is working fine and it pulls the left half of the soft palate upwards and it shifts the uvula to the left side. What happens if the vagus is injured? If the vagus is injured bilaterally, and this is not a common sort of thing to happen, but in fact there was a paper, interestingly, in 2003 about a person who had cancer of the throat and they had massive metastasis bilaterally to the deep cervical nodes. And I didn't, because the paper was in a language I don't read, which was Spanish. And not only that, but I couldn't even get it. I mean, it was in some journal. Can you believe it, Chirag? You could not download this paper.
You didn't download it?
So I couldn't even get a Spanish-speaking person to read it for me, but I could read the abstract, which was in English. It wasn't clear whether the vagus was damaged accidentally in the process of removing all of these cancerous lymph nodes bilaterally, or whether it was done on purpose because it was so caught up in these nodes. But anyways, this person had a bilateral cut of the vagus. It was below the palatal branches. It was in the neck, so the person would have been able to say, it would have looked normal at that time. But the symptoms they described in this person, which are symptoms that have been described previously in very old books, when people would have horrible injuries that no one could treat, were largely, and would have caused the person to die untreated. So if you have bilateral vagal, you're going to die if you're untreated. And that's because, number one, your stomach doesn't empty. Can't relax the pyloric sphincter, and you have no peristalsis in your stomach, and eventually you die of malnutrition and bloating, and they even had very bad things happen if your stomach can't empty. You can't live very long like that. And number two is the person had cardiac arrhythmia, because you remove the vagal innervation of the heart, but you still keep the sympathetic innervation of the heart, and you still have the heart responding to circulating sympathogenic hormones like adrenaline and noradrenaline. And the heart rate gets faster and faster, and then it becomes arrhythmic. And so this usually is considered fatal to have a bilateral vagal injury, so it's nothing you're going to have to worry about very long time. But you can treat some of these nowadays. You can put pacemakers in, and you can do a pyloroplasty and things like that, and the person wouldn't die. But then they'll have all these other things we're going to talk about in worse form. Now, what happens when it's injured unilaterally, which is in fact certainly more common than a bilateral injury, though not all that common? Number one, you get slight dysphagia. Dysphagia is difficulty swallowing. That's what dysphagia means. And you have difficulty swallowing because the vagus is very important in the swallowing mechanism. You've heard about tensor veli palatini being important because it makes your soft palate tight and restricts, and the palate can then, when it's tight, restrict passage of food into your nasal cavity. But even before that, you need to do the following things. You need to elevate your soft palate when you're about to swallow something. And then you need to bring the front wall of your pharynx forward to meet that elevated soft palate. And in that way, you do actually close off the passageway from the oropharynx up into the nasopharynx and stop food from regurgitating from your mouth into your nose. And then the tongue just pushes the food backwards and it drops down into your throat. So the vagus is very important in closing off the oropharynx from the nasopharynx. And if you cannot do that on one side, doesn't make any difference how tight your palate is. If you cannot close off the nasopharynx from the oropharynx on one side, you're going to have some problems swallowing. Largely, you will get nasal regurgitation of fluids and things like that. But it's not a terrible problem, because generally things tend to fall down, not to go up. So it's only said to be a slight dysphagia. Nasal speech, Dr. Degum tried to imitate nasal speech. I'm from Chicago, since all my A's are nasal. I mean, people from Chicago don't say ah, they say eh. But again, if you cannot close off your oropharynx from your nasopharynx, then there's a little nasal quality to your speech, not things that's terribly upsetting to you. Then this is what's the big problem. If you denervate all of your laryngeal muscles on one side, you really give yourself some problems. Here is a schematic diagram looking down onto your thyroid cartilage. Here would be its angle, doesn't look much like an angle. And here would be the laminae on each side. And we have to go through the normal positions of your vocal folds to discuss what their position would be if you remove the innervation of all of the muscles of one side. These are named positions of the vocal folds. When they are together in the midline, touching one another, and that would only be if you want to increase your intra-abdominal pressure or just before you cough, closing off your glottis tightly. The positions are said to be in the median, the vocal folds are said to be in the median position. If they are as wide apart as they can possibly get, as if you were running up and down stairs, and so you really needed to reduce all airway resistance, that's called maximum abduction. If they are very near the midline but not touching, and this is the position of speech essentially, your vocal folds don't touch one another in speech because the air has to pass between them and vibrate them. So the very near the midline, the position of speech is called the paramedian position. If they're halfway between maximum abduction and the median position, that's called the intermediate position. It used to be called the cadaveric position because it's what they go into if you're dead, but now it's just called the intermediate position. And then there is the position of quiet respiration, which is just you as you are now. They tend to oscillate, obviously, about this position, a slight oscillation about this position, which is sort of between the maximum abduction and the intermediate position. So what activities is the larynx important for? We're going to get to what happens when all the muscles are paralyzed in a moment. What activities is your larynx and vocal folds important for? What are they important for? Speech, obviously. So being in the paramedian position, that is what they are in speech. You can speak. You can get intelligible speech if they can be brought close together, and only one of them can be made tight. You do get intelligible speech. If they are brought close together, but only one of them can be made tight, so its vibrations are not the way it should be, you get a hoarse and breathy speech. But you can get intelligible speech if they are brought close together and one can be made tight. Breathing. They're important in breathing in the sense that they have to get out of the way. That's their only role in breathing, is to get out of the way. They're very important in coughing. This is actually a very stringent requirement, more stringent than in speech. Because in order to cough, you have to be able to bring them to actually touch one another, and both of them have to be made tight. So you can hold them tightly opposed to one another, so you can build up the pressure and then let it out, which is the cough. So coughing is actually far more demanding on your vocal folds than is speech. And so is protecting the infraglottic airway, that is stopping you from inhaling and things into your lungs that don't belong there, things you eat. And they have to be brought together tightly. and oppose one another to prevent things from getting into your infraglottic airway. So these are the 4 functions of the larynx and an indication of what the vocal folds have to be able to do this. So what happens if all of the muscles are paralyzed on one side? Well, when all the muscles are paralyzed on one side, that vocal fold goes into the intermediate position. All right? And when that vocal fold is in the intermediate position, you have to ask yourself, which of these things will be affected? Speech will be affected, but it will not disappear. You would say, well, one of them is in the intermediate position and the other one can't get any further than the median. You can never get them close enough together to talk. But in fact, by proper use of your vocal musculature, you can actually swing a vocal fold to the opposite side of where it normally would be. You can bring the good vocal fold close enough to the paralyzed intermediate fold and narrow the gap between them enough that you can speak. And since the good one can be made tight, you get intelligible speech. It's just a hoarse and a breathy kind of speech. So speech is affected, but not eliminated, yes?
Could they eventually lose it because it puts so much stress on it?
The question is, could they eventually lose their ability to speak because it puts too much stress on the good vocal fold? And the answer is, I've never read of that occurring. I've never read of that occurring. Also, if you read the clinical sidelights, there is a tendency, for reasons I don't want to get into here, but as discussing clinical sidelights, for a paralyzed vocal fold to actually move medially over time, and therefore for speech to improve over time. Now, it doesn't happen in everybody, but it happens in quite a few people. But I've never heard of damage to the intact fold. Breathing, well, one fold is in the intermediate position, can't get any further out than that. The other one can go all the way to maximum abduction. That really is a big enough gap between the folds for you to breathe pretty well, unless you're doing something like running up and down stairs. And if you're running up and down stairs, you may then feel what's called dyspnea. I don't know if I have the word here, but dyspnea is difficulty breathing. So this would be exertional dyspnea. You would not have any problem normally, but if you were engaged in very strenuous activity, since one of the folds could not move to its maximum abducted position, there would be a narrower opening than you are accustomed to having in extreme exercise, and you might have some dyspnea and stridor, which is sort of a whistling sound. That's a whistling sound when the air is passing so fast between these folds that are not far enough apart, you get a little stridor. Coughing is greatly affected. Since that one, you cannot bring the two folds to touch with both of them being tight. One of them is always loose, and therefore you really cannot build up a lot of intrathoracic pressure and cough. So coughing is greatly affected. That's a bad thing not to be able to cough. You really need to be able to cough to clear your airway of junk. And protecting the inflammatory airway is affected as well. Since you cannot really tightly seal off that space, you do tend to aspirate liquids more so than solid foods into your airway. So it's a bad thing to have a paralyzed vocal fold. What happens if all of the muscles are paralyzed bilaterally? Now you can have that obviously in the case of the person who has the bilateral vagal damage. They will all be paralyzed bilaterally. You can have it in people who, and this is recorded, not so much nowadays, but I mean there certainly are people who've had thyroid surgeries and esophageal surgeries where the physician mistakenly cut both recurrent laryngeals or damaged both recurrent laryngeals. And that's a very bad situation to be in. Worse than it seems, because having two in the intermediate position, well, you can still breathe. You can't cough. You can't protect your infraglottic airway at all. You can't speak, really. But what happens is, with these two sort of floppy folds in the intermediate position, as air passes between them, you get what is the Bernoulli principle. It tends to suck them in together. And they get closer and closer. So then you really can't breathe anymore. And so this is an emergency situation. If a person has two paralyzed vocal folds, you have to go in and emergently open up their airway because the two folds will be sucked together as air passes between them. All right, so that's enough for the vagus. Going to the accessory, the easiest of them all. And finally, I get, again, to pretend I'm a doctor here. I will do, Thomas, you can join me because you're right up in front. I'm not going to hurt you. Know how to do this anyway. This is the test for the accessory nerve. The accessory nerve only does two things. Innervates your trapezius muscle and your sternocleidomastoid. And in particular, it innervates the upper part of trapezius in everybody. Some people, it innervates all of trapezius. But in some people, C3 and C4 innervate the lower part, and accessory only does the upper part. So it's very easy to test for accessory. Please shrug your shoulders. Don't let me push them down. All right, that's it. For accessory, or if you want to test sternocleidomastoid, please turn your head to the left. Don't let me push it back. Turn your head to the right. Don't let me push it back. Thank you. You did a good job. That's it. That's it. It's a very quick and easy test. You may be able to test accessory in everybody. You test them both. It's possible clearly to get injuries to the posterior triangle that only affect the trapezius. But if you, the sternocleidomastoid and trapezius will both be affected in a high injury of the accessory. Yes?
Is there another where you put the head up and then ask them to point down?
You can ask the person to bend their head down, and you can palpate both sternocleidomastoid tendons and see if they're equal. But when I did it on Marshall, it didn't seem that they were hardly contracting at all. So that's it.
I was just wondering about sneezing, if that's the same as coughing and that it involves.
I would have to think about it. Do you actually have to close off your glottis when you sneeze? I don't think you do. I don't think you do.
What's a sneeze?
And the function of sneezing is something I don't know about. It may clear your nasal, but I don't think sneezing clears out your bronchial tree, just maybe your nasal cavity. All right, so the hypoglossal nerve. We know about these two things, and the final component of Cern's law is any muscle with the letters gloss in their name are innervated by the hypoglossal nerve, unless you had a muscle called palatal-glossus. Could there ever be such a thing? And the answer is yes, there is, and it's innervated by 10. And is there a muscle called tensor glossae? And the answer is no, there isn't, so it's irrelevant for that. So all the tongue muscles, essentially, except for palatal-glossus, are innervated by the hypoglossal nerve. Among the tongue muscles, and there are many intrinsic muscles of the tongue, ones which go from side to side, from the top of the tongue to the bottom of the tongue, which just alter its shape. There are some extrinsic muscles of the tongue as well. There's styloglossus, which pulls the tongue backwards and upwards, very important in swallowing, because you want to pull the tongue backwards when you swallow, so it drives the food into your throat. There's a muscle called hyoglossus, you'll see, which flattens your tongue out. I'm not sure when that's particularly important, but it exists. And then there's other muscle called genioglossus, which arises from the inside surface of the bone of your chin, or the inside part of your mandibular symphysis, and radiates backwards into the tongue. And so when it contracts, it actually pulls the base of your tongue, this part back here, pulls that forward, genioglossus. Here is a tongue looking down on the top. There's a right genioglossus and a left genioglossus. Each one pulls the back part of the tongue forward. So if you contract both of your genioglossus muscles, the tongue sticks out. You have to stick your tongue out at someone by contracting your genioglossus muscles. But that's the same, in a way, of what happens in protruding your jaw by contracting your protractors of the jaw. Some on the right, some on the left. And you pull it and you push your jaw forward from the back. If only the left genioglossus muscle works, the tongue will deviate to the right side. And again, this is just like the situation with your jaw. If only your left jaw protractors work, the jaw deviates to the side of weakness. So it's exactly the same, but just from the tongue point of view. Here is a test of the tongue.
The last cranial nerve would be the cranial nerve number 12. And I want you to stick out your tongue all the way out. Comes out at the midline. I want you to go in and out, this back and forth. Put your tongue over on this cheek. Push out.
That cheek test is an important test. Because in order to push out the right side of your cheek, you use your left genioglossus. Your left genioglossus is what shoves the tongue to the right side. And it's a test of strength. So when you try and push the tongue back, you are testing strength of your left genial glossus if it's pushed out the right cheek. Similarly, in order to push out your left cheek, you are testing the strength of your right genial glossus. That is probably a better test of the genial glossus than is just wiggling from side to side. But let's take a look at the person who's got a genial glossus problem, or at least a tongue problem.
So you got your tongue all the way out. And again, we're just going to...
Now we look at that, and the tongue is very obviously deviated to one side. And you would say to yourself, that this person's right genial glossus isn't working correctly. But in fact, most of the reason the tongue looks deviated is due to atrophy of the muscles on this side.
Why is it the right?
The right side isn't working correctly. You know what I said?
So shouldn't it be the...
Yeah, because the left side is pushing the tongue toward... Yeah, that's correct. The left side is pushing the tongue towards the right, but the right side can't counteract it and push it to the left. Now, this is a case of a right-sided problem. But, if you look at the back of the tongue, it looks pretty straight. It's mainly atrophy of the muscles here, and you'll see some other tests which are better for genial glossus.
Okay, and then all the way out as far as you can. See if you can get all the way out of your chin. Good. I want you to move your tongue over here to the right side. I want you to move over to the left.
See, he's able to move it pretty well to the left.
Over here again, and over here again. Okay. And I want you now to stick it all the way out. I want you to push against the tongue blade.
That's testing the left-sided muscles.
And I want you to push over here, the other side now. All the way over here. And now let me push it back.
And that's testing the right-sided muscles. And that really...
Again. And let me push it back. Push it back. Okay, good.
That really reveals the weakness of the right genial glossus. The person just has no strength in pushing to the left. How he got it to the left at all is sort of a mystery to me, but maybe he only had a partial problem. I don't know. What activity is the tongue important for? All these things which are up here. When you have a complete denervation of one side, generally these things are not affected in a major way. The person doesn't really have a lot of problems. When you have bilateral hypoglossal injury, then the tongue you can't use it for any of these things effectively, and then you have terrible problems speaking and chewing and swallowing and all of those things. So bilateral produces problems in all of these things, and unilateral not so much. All right, now we'll close off with the sympathetics supply to the head. It is not a cranial nerve. We covered all the cranial nerves. So this is now just, and that means by covering all the cranial nerves, we covered all the parasympathetic supply to the head. They came out with oculomotor, facial, glossopharyngeal, and vagus. Those are the nerves that carry parasympathetics to the head. But sympathetics to the head don't travel out of the brain with cranial nerves. The postganglionics all come from the superior cervical sympathetic ganglion, which you dissected just Monday. That is the cell bodies for the postganglionics all lie within the superior cervical ganglion. They have two main roots. One is along the internal carotid plexus of nerves, and the other is along a plexus which follows the external carotid and all of its branches. So by and large, these postganglionics are brought to the things that are going to innervate by vascular plexuses. Now, of course, some nerves jump off the internal carotid plexus in the cavernous sinus to join V1, abducens, and oculomotor and things like that, and then are carried into the orbit by those nerves. But they got as far as they did by traveling along the side of the arteries. And the external carotid plexus carries a lot of things for obviously sweat of the face and anything like that. Where do the preganglionics lie? They lie in T1, T2 of the spinal cord. T1 probably, we'll talk about that in a second. So they lie in T1 to T2 of the spinal cord. They go into the T1, T2 paravertebral ganglia. They ascend without synapse up to the superior ganglion where they synapse. What do the sympathetics to the head do? They do essentially four things of consequence. Well, maybe 5 because I didn't list the 5th one. They innervate the dilator pupillae. We know about the sphincter pupillae, a muscle innervated by the oculomotor nerve, it's parasympathetics, which causes your pupil to get smaller. Well, there's an active muscle called the dilator pupillae, which causes your pupil to get bigger. And if you shield one eye from light, you can see the opposite eye's pupil. It's a consensual reflex. The opposite eye pupil will get actively bigger by contraction of the dilator pupillae. The innervated muscle called Mueller's muscle, I've seen a couple of them in my life, you have not. It's a smooth muscle layer on the deep aspect of the aponeurosis of the levator palpebrae superioris. And that smooth muscle actually contributes to the normal resting posture of your upper lid. It helps to elevate your upper lid. It assists, if you will, the levator palpebrae superioris in elevating your upper lid. It's not as strong and is not as important, but it does assist it, and when it's knocked out, there is a sign of the upper lid that shows that. It causes you to sweat your face when you sweat under a thermal load. That is, you put yourself in a hot room, it causes your face to sweat. It does not, the sympathetic system does not cause you to have what's called gustatory sweating. Gustatory sweating is when you eat very spicy food. And especially if you get a mask of sweating across your face like that, that is considered, it is parasympathetic. That's known to be parasympathetic. Not so clear about the sweating of the top of your forehead. That might actually be sympathetic, but I don't want to get into that. The mask of sweating across your face is definitely parasympathetic and you eat spicy food, yes.
I thought sweat glands were innervated by sympathetics. How do parasympathetics cause sweat?
Well, this is the rare case when sweat glands have a parasympathetic innervation. And one of you had mentioned to me in class something that's true. When you do a parotidectomy, or when you do a partial parotidectomy, all right, and because of tumor, one of the big problems that occurs is that you are cutting all of these parasympathetic axons that are going to parotid tissue that you have removed. And what these parasympathetic axons do is they grow into your skin and innervate more sweat glands. And so that every time you even start to chew, and your brain sends information to your mouth saying, produce saliva, I'm eating something, you get a big band of sweat where your parotid gland used to be. That's called Fry's syndrome. And in most people, and so it's a case where parasympathetics, with nothing to do because you took away their gland, just go out and do the sweat glands over the skin overlying where the gland used to be. You can actually get in the submandibular gland surgery too. You can get a sweating of the skin underneath your chin as a result of instructions to salivate. That is generally treated with antiperspirants, actually, but not always successful. And then, and some surgeons, in order to avoid the problem, will actually go and put a little. There's a name for it. I can't remember the name of it. It's a little kind of tissue you get from a tissue bank that just is a barrier between the cut surface of the gland and the skin to stop these parasympathetic axons from going out and innervating your skin. So, in answer to your question is, most of the time it's sympathetic, but in a few cases, in this one case really, there's a normal parasympathetic innervation for gustatory sweating and can be an abnormal after surgery of the salivary gland. And the sympathetics cause also a cutaneous vasodilatation of the vessels of your skin. That's what cutaneous vasodilatation is, the vessels of your skin, when either you are embarrassed, or when you are, again, put in a hot room and the blood vessels dilate for heat dissipation. So these are essentially the 4 things. The 5th thing, which I didn't add, is they tend to cause a vasoconstriction of most intracranial vessels. They cause vasoconstriction of your ocular vessels, that's mentioned in core, and they cause vasoconstriction of your cerebral vasculature as well. So I should have put that in, but I didn't do so. So they have an opposite effect on intracranial vessels that they do on cutaneous vessels. Horner syndrome is the classic, and there's got to be one on step 1 or step 2 or every step you'll ever have. Horner syndrome is the classic syndrome of signs and symptoms when you have damage of the sympathetic supply to your head. It will occur if you damage the T1 vertebral ganglion, or if you damage anything running up the chain, the cervical chain at all. You will in that way eliminate the sympathetic supply to the head. It's an annoying set of symptoms, and this is why when we talked about cutting out sympathetic ganglia to treat sweating, if you read about it, or if you will, we talked about cutting out sympathetic ganglia to control angina in that rare case where you can't control it any other way. If we haven't already, if you haven't read in clinical sidelights talking about it to control excessive sweating of your palms, or cutting out sympathetic ganglia, the one you never cut out is T1, because T1 is en route. That's the passageway for these preganglionics that are going up to the head. They all pass through T1. So you never take out T1 because you will produce a Horner syndrome if you do. And the Horner syndrome symptoms are an upper lid ptosis, just like an elevator palpebrae superioris paralysis, except that it's a much milder and much less marked ptosis than an elevator palpebrae superioris, because Mueller's muscle is less important than the LPS in elevating your upper lid rests. Meiosis is a constricted pupil. If you have a damage to your sphincter pupilla, you get a dilated pupil. It's unusually large. We saw that, I think, in one of the pictures. Meiosis is an abnormally constricted pupil on the side of the injury, and that's the opposite of what you would get in an oculomotor injury. And here is a person with a Horner's syndrome. And you can see, number one, that one of the eyelids droops more than the other, but not terribly, not as in a levator palpebrae superioris. And you can see that one of the pupils is smaller than the other. Whenever you look at people's pupils, you always look for variation in size. And this one is, this upper lid is drooping compared to that one. This pupil, in effect, almost covers the pupil. In a levator palpebrae superioris paralysis, it almost certainly would cover the pupil. Almost covers the pupil, and the pupil on the left side is smaller. And you see, interestingly, and this was pointed out to me by a student a year or two ago, and I had never noticed it after seeing the slide for many years, there is a vasodilatation of the conjunctival vessels, because these are branches of the ophthalmic artery, and the sympathetic system produces vasoconstriction of ophthalmic artery branches. And so you do get a vasodilatation of the conjunctival vessels on that side. So these are two of the symptoms of a Horner syndrome, and the others are you get no sweating on the side of the injury, and if you are a light-skinned person and you embarrass them or something of that nature, put them in a hot room, there will be no vasodilatation, no reddening of the face on the side of the injury. So these are the four complete symptoms of a Horner syndrome, and these upper two are called the ocular symptoms of a Horner syndrome. Partial Horners, and that's what I'll close with. The pathway to the eye of the sympathetics is along the internal carotid plexus. As we said, it gets into the cavernous sinus. Some of them jump onto the oculomotor nerve and are carried to the eye that way. It just so happens that whereas all the sweat glands of the lower part of your face are handled by the external carotid plexus, the sweat glands of your forehead are handled by the frontal nerve and its supraorbital and supratrochlear branches, which has picked up sympathetics when they jumped from the internal carotid onto V1 in the cavernous sinus. So this is a case where the innervation of the sweat glands of your forehead is rather different in how it got there than the innervation of the sweat glands of the lower part of your face, the lower two-thirds of your face. A partial Horner syndrome occurs in some people who have migraine headaches, very bad migraine headaches. Migraine headaches are due to vasodilatation of the intracranial vessels. And why it causes pain, I don't know, but it really does. But a migraine headache also, among the vessels that dilates in a migraine, is the internal carotid artery. And if the internal carotid artery dilates too much within the carotid canal of the petrous temporal, it will compress the internal carotid plexus of nerves up against the bone of the carotid canal and will cause them to suffer a compression injury. So that internal carotid plexus is sympathetic. So you can be left with a loss of the sympathetic innervation that has traveled up that internal carotid plexus without affecting the sympathetic innervation that has traveled along the external carotid plexus. So you get a partial Horner's. You get all the ocular symptoms that I mentioned. You get a mild ptosis and a miotic or a small pupil. You also get loss of sweating on the side of your forehead, but no loss of sweating from the eye down, which are carried by the external carotid plexus. And there's quite a few reported cases of these partial Horner syndromes in people with migraine headaches. So you just need to know some anatomy to explain the symptoms. That is all I have to say about this.